Hi everyone, my name is Alexis McKinley, and today I'm going to be discussing the pathophysiology of migraine and the role of CGRP inhibitors in treatment. To introduce migraine, migraine is a disabling neurological disease with varying symptoms thought to be linked to genetic and environmental factors. These symptoms can include intense, throbbing headache, nausea, photophobia, phonophobia, and osmophobia, as well as fatigue, visual disturbances, and sweats or chills. Migraine is also classified as either episodic or chronic. Episodic migraine occurs when a person experiences 14 or fewer headache days a month, while chronic migraine, on the other hand, is defined as having more than 15 headache days per month for at least 3 months. Migraine cannot be diagnosed through standard diagnostic tests. Instead, doctors typically assess a patient's condition by evaluating the characteristics of their head pain, their response to past and current treatments, family history, and the impact on daily life and overall well-being. A general medical examination and a comprehensive neurological assessment are usually conducted to support the diagnosis. Approximately 14 to 15% of the global population is estimated to have migraine, though the actual number may be higher, as many individuals remain undiagnosed or do not receive appropriate treatment. Migraine is nearly 3 times more prevalent in women than in men as well. Migraine is also the second most disabling condition globally, impacting various aspects of life, including work, education, social interactions, family dynamics, and personal well-being. So now we're going to discuss the phases of migraine, which is shown in the image on the slide. A migraine attack consists of 4 distinct phases: prodrome, aura, headache, and postdrome. The prodrome phase, experienced by about 75% of individuals with migraine, can occur hours or days before an attack and is typically characterized by symptoms like fatigue, frequent yawning, irritability, mood changes, difficulty concentrating, and food cravings. Aura occurs in about 20% of individuals living with migraine and typically begins just before the headache phase and is most commonly associated with visual disturbances. It's key to recognize symptoms early when treating a migraine attack because it can prevent further symptoms from developing in some individuals. The headache phase of a migraine usually causes pain on one or both sides of the head and lasts several hours to 3 days. It can also be accompanied by nausea, vomiting, or sensitivity to light and sound. The last phase is known as the postdrome and affects about 80% of individuals with migraine and includes symptoms such as fatigue, body aches, difficulty concentrating, dizziness, and light sensitivity. So now we'll talk about the pathophysiology of migraine. Migraine pain is primarily processed through the trigeminal nervous system. Sensory signals from the brain are transmitted via the trigeminal ganglion to the trigeminocervical complex, which serves as the main connection between the peripheral and central nervous systems. From there, pain signals travel through the trigeminothalamic tract to the thalamus, where they are relayed to different brain regions involved in pain perception. Along the way, these signals interact with brain areas like the periaqueductal gray, the hypothalamus, the locus coeruleus, and the rostral ventromedial medulla, which can help regulate pain intensity. This can be seen in images A and B. Additionally, the trigeminal autonomic reflex, which involves the sphenopalatine ganglion, contributes to autonomic symptoms such as tearing and nasal congestion. And this is shown in images C and D. So this complex network is influenced by descending brain signals that modulate pain perception, which makes migraine a highly dynamic and multifaceted neurological condition. So now we'll discuss the role of calcitonin gene-related peptide, otherwise known as CGRP. CGRP plays a key role in migraine pathophysiology by acting as a potent vasodilator and neurotransmitter in pain signaling. When a migraine attack occurs, CGRP levels increase, leading to inflammation, dilation of blood vessels, and the activation of the trigeminal nerve, all of which contribute to migraine pain. So there are several classes of migraine treatments that are widely used and supported by strong evidence. Some examples of these are non-steroidal anti-inflammatory drugs, otherwise known as NSAIDs, which are ibuprofen and naproxen. These are over-the-counter abortive treatments. Another example would be triptans, like sumatriptan, which is a prescription abortive medication that's typically used when other therapies are ineffective. Yet another example would be beta blockers, such as propranolol, as well as certain epileptic, anti-epileptic, and antidepressant medications, which are commonly prescribed for migraine prevention. Botox is also a preventative migraine treatment that blocks nerve signals that are responsible for pain and inhibit the release of chemicals involved in migraine pathways. These treatments can be effective for some patients. However, they may have adverse effects and contraindications. Now I'm going to discuss CGRP inhibitors as a new treatment approach for migraines. CGRP inhibitors block the effects of CGRP, which is a small protein that's abundant in the sensory nerves of the head and neck that play a key role in pain transmission. There's two types of CGRP inhibitors: CGRP monoclonal antibodies and small molecule CGRP receptor antagonists. There are currently 4 FDA-approved CGRP monoclonal antibody injections available for preventative migraine treatment, while there are 3 small molecule CGRP receptor antagonists that are used for acute migraine treatment. Due to their large molecular size, CGRP monoclonal antibodies are typically administered parenterally and do not cross the blood-brain barrier or undergo hepatic metabolism. Now, there are some benefits and challenges of CGRP inhibitors. As of 2024, the American Headache Society updated its position statement, recognizing CGRP targeting therapies as a first-line option for both the acute treatment and prevention of migraine. CGRP inhibitors are generally better tolerated and have fewer side effects compared to traditional abortive and preventative migraine treatments. While this type of treatment is generally well tolerated, the long-term side effects are still being studied, and particularly regarding cardiovascular and immune system implications. CGRP inhibitors also tend to be pretty costly compared to traditional migraine treatments, and insurance coverage may be limited for some patients as well, making them less accessible. So in conclusion, Migraine is a complex neurological disorder that affects millions worldwide, significantly impacting daily life and overall well-being. The trigeminal nervous system and CGRP also play central roles in migraine pain transmission. Traditional medications used as abortive and preventative treatments are effective, but may have side effects and contraindications. However, CGRP inhibitors, which are a breakthrough therapy in migraine treatment, target CGRP to reduce migraine frequency and severity, with better tolerability than traditional treatments. Although there are several challenges associated with CGRP inhibitors, they remain the best available treatment for individuals living with migraine. Continued research and advancement in migraine treatments will improve outcomes and accessibility for patients. These are my references, and thank you for paying attention to my presentation. I hope you enjoyed.